So again, a great pleasure to invite our next speaker, Dr. Renana Eitan, who just joins the Jerusalem Mental Health Center and the Hebrew University of Jerusalem. Renana studied medicine at the Hebrew University School of Medicine and trained in psychiatry at Hadassah. She, after finishing her residency, was the founding director of the first neuropsychiatric unit in Israel, called Nofal, right, at Hadassah, and then went on to be a researcher at the Brigham and Women's Hospital at Harvard Medical School for 2 years, 2.5, 2 and 8 months, but who counts? And like many other people here who came from abroad to give talks, she also landed 2 days ago, but she made a much bigger change than many other invited speakers from abroad because she's here to stay. So we will hear about her work in deep brain stimulation research in psychiatry, where she and colleagues focus upon the development of new electrophysiological techniques in human patients and non-human primates to localize and characterize the brain circuitry dysfunction underlying psychiatric disorders. So Renana will tell us all about it, and let's welcome her.
It's a great pleasure to be back home. Thank you for inviting me and making sure that I'm coming back home to Israel. So Benny asked me for 2 things. Full review of DBS in psychiatry and no greetings in 30 minutes. This is quite impossible, but Dr. Sackeim gave us a short introduction for DBS, so I have 1 minute for greetings. So first, Benny is not my first teacher here. My first teacher here is Tziona. She was my English teacher in elementary school. And for me, Benny is also not only the father of the biological psychiatry in Israel. He's also a father of 3 of my close friends, Tzariel, Elad, and Shira. But of course, Benny is my mentor. I try to explain people why I leave before the summer. Why won't you take a trip in the US before you go back to Israel? And I told him that, Benny, I can't call you my former mentor, or I can say that you were my mentor, you are my mentor. And I think that for many of us, your mentorship is one of the most important things that happened to us in our career. So I met Benny in Alon Shvut many years ago. The first talk was in Bnei Akiva during high school. So Benny is the first psychiatrist that I actually ever met. And he convinced me to come to Hadassah for my residency. I was after giving birth to my first child, and I was a little bit depressed and I think psychotic, and I agreed. And then it got me into the field of ECT. We started together the ultra brief ECT. And from there, the way to brain stimulation was very short, and I thank you for that. Okay, so I'm supported by these things. We'll speak today a little bit about deep brain stimulation. We'll review the different targets in the brain that we have for brain stimulation, the exact location for placing the electrodes, how do we stimulate the brain, specific patients that we treat, and a little bit about the study design of DBS today, and some future challenges in this field. Okay, so deep brain stimulation is actually, I know that most of you already know, we put a very small electrode deep inside the brain and we connect it to a pacemaker, and this allows us to control a specific brain area. So why do we use DBS? I think that the answer is similar to ECT because it works. The clinical effects of DBS are very interesting, and we are not treating the most severe patients, treatment-resistant patients like in ECT. we treat those patients that failed ECT. So these are not the most resistant, but even worse. DBS is a reversible procedure. For many years, we could have done ablation procedures to go into a specific brain area and make a small lesion. And it also works for depression, for psychosis, and for OCD. But the problem is that this is a non-reversible procedure. So if we miss the target a little bit, or we missed we didn't choose the right patients, so we couldn't do anything about it. With DBS, we can actually directly control the changes in the brain activity, and we can adjust the stimulation to the specific state of the patient. And this is a major thing about DBS that we couldn't do with previous brain stimulation activities. But we have to remember that DBS is an operation. We have to make a small hole in the skull and put the electrode. There are risks of bleeding or local infections. These are mild risk, but of course we have to remember that it's not like taking a pill. The milestone of DBS did start with Professor Ben Abid in Grenoble, who started the first thalamic DBS for Parkinson's disease, and that was actually based on the work of Mellon DeLong. His most famous paper in Science, was written by Chagai Bergman, my other mentor, who suggested the subthalamic nucleus for DBS for Parkinson's disease. In 1999, Bart and Eitan published the first cases of DBS for OCD, and in 2005, Ellen Mayberg and Andrea Lozano published the first 6 cases of DBS for depression. In 2013, there was a big celebration in Grenoble, celebrating 25 years for DBS for Parkinson's disease, and they reported over 1,000 patients. So if we think about psychiatry, we have at least 10 or 15 years from now to celebrate 1,000 patients, but we'll see what's the difficulties, the specific difficulty in psychiatric patients, and especially in DBS. I hope that we will have these numbers, or maybe close to these numbers, soon with our new ideas and treatment that we have now. So we'll focus on the main indication for DBS, which are today Parkinson's disease and the other movement disorder family, essential tremor and dystonias, and the 2 major indications in psychiatry, which are major depression disorder, obsessive compulsive disorder. I just want to mention that there is an increasing literature about other psychiatric disorders or neuropsychiatric disorders such as Tourette, addiction, Alzheimer's disease, anorexia, and we are dreaming about the future for schizophrenia. If I have to summarize my talk, I would say that the most important thing about DBS in psychiatry is the fact that it finalized the idea that the psychiatric diseases, of course, are brain diseases, but these are circuit diseases. It's hard to understand what is a circuit, so the neurologists always tell me, okay, but where is the focus? Where is the locus of depression? Of course, we don't know, and we have to say that this is a circuit. But with the DBS, we now know that if we can change this circuit, and not exactly in the locus of depression, but somewhere within the circuit, we can treat depression. And I think that this finding actually moved the field of psychiatry into a more consideration of the brain circuits. And for me, this is the most important thing about focal brain stimulation, and especially of DBS. I will not get into all the circuits, okay, because it's not for a 30-minute talk, of course. But we are talking about the circuits that involve the prefrontal cortex and the striatum and the basal ganglia. And there are many types of circuits that we want to influence when we want to treat depression and OCD. For example, things that are related to our positive affect, to our negative affect, to attention, to cognitive control. And of course, we cannot treat everything because the brain circuits, they're a little bit apart from each other. It's not that we can stimulate now the whole prefrontal cortex, which is involved in the mechanism of depression or of OCD. We have to choose a specific place or a specific network. And people have tried to stimulate different nodes on these circuits. As you can see, go to the anterior cingulate cortex, to the subcallosal cortex, to the insula, amygdala, of course, all the ventral striatum and the nucleus accumbens. All these areas and the connections between those areas have been targets for DBS. But as years passed by and we had more experience with DBS, we realized that with this tool, which is a very, very small electrode that you place in a specific area of the brain, we have to choose a different target. And this target, I think, is going through the funneling, the natural funneling pathway of the brain, which is the basal ganglia. Okay, so the basal ganglia actually gets the information from the cortex, and if we get into the basal ganglia, we can actually influence on the cortex. To give you an example, I'm standing here, and you're all listening to me. Okay, so you'll be my cortex, and I'll be the, let's say, the subthalamic nucleus. Okay, so I can get information from the cortex. I see those people that are sitting near the door, and I know that they will probably go out in a few minutes when it's getting like too bored. I see those people in the front line. I see the people that write things. Okay, so I can see the audience and I can interpret what's going on here. Okay, because I'm standing here and I can see the whole cortex. I can ask specific questions. For example, how much time do I have today? 30 minutes, okay? So now I get specific answer from the cortex, okay? And if you want to influence what's going on now in this room, the best thing is to address me, okay? If emergency, we have to evacuate this room, okay? So the best way is not that one of you will tell it to me and I'll announce it to the cortex, so that if you want to influence what's going on in the brain, the best way is to go to this area where you can control the cortex and to get the information from the cortex. So these areas of the cortex that we know for many years that are related to motor activity, to the limbic, and to the associative areas are also represented in the basal ganglia in different areas, as we'll soon see. And we can influence specific areas within the basal ganglia by addressing the specific area. The problem will be to find, of course, these specific areas of the brain. Okay, so this is just a nice illustration. We have lots of them today. Okay, so here you can see the electrode within like specific fibers or a nuclei within the basal ganglia. And this is the idea, to get into this small place in the basal ganglia and stimulate there and change the function of this specific cortex. Okay, so after we choose the right target, of course, I mean, I prefer, you all know the subthalamic nuclei, but others can choose their own target. The next challenge would be a specific location. Okay, how can we locate an area which is 9 centimeters from the cortex with a small hole in the skull? So the best thing, of course, is the very sophisticated MR-guided navigation system that we can make MRs and CT scans and combine them and find the right target. You see that we argue about each patient, where should we put. This is Dr. Tzvisa, the head of functional neurosurgery in Hadassah, and before the surgery we were sitting together and trying to figure out what is the best location and the best targeting for that location. But we can also have electrophysiology. Because we have a needle or we have an electrode deep inside the brain, we can record the electrophysiological activity and to make sure that we are in the right place. Because, of course, when we have the MR, but we then make a small hole in the skull, so we have a mild CSF leak, and the brain can shift a little bit. And we are talking about, place that we want to make sure that within 1 or 2 millimeters we're exactly at the same area that we wanted to target. So we can actually make a recording of the brain as we get into the deep structure of the brain. And this is just an example. Okay, here we have the location of the subthalamic nucleus, as we decided by the MR scan before the surgery. And then we start recording. And you see here, maybe I can show you. Okay, you can see here that the type of the activity of the brain has changed. This is where we got into the subthalamic nucleus, and then we can change our prediction a little bit and make sure that the electrode is exactly at the center of the subthalamic nucleus. We can do it only when we have very smart electrophysiological people inside the OR. So we actually, during the past 2 years, developed a new automatic detection of the STN, so that in more operating room around the world, people would be able to use our algorithms to define the exact place of the subthalamic nucleus. Another thing is that we can use some more advanced imaging techniques like the 7T MR scans, and we actually made a nice collaboration with the University of Minnesota during the past 2 years, and we showed that actually the electrophysiology that we record fits the 7 Tesla imaging that we get from Parkinsonian patients. So we found the target, we found a specific way to locate the electrode, but now we have to know how to operate the pacemaker. So if you've ever done an ECT, you know that you have to use the right frequency, duration of pulse, and all these things applies also to the pacemaker that we had. And we also have 2 contacts in each electrode. So the 4 contacts is the traditional DBS electrode. Today we have electrodes with 16 contacts, 24, and in the future we'll have much more. So we have to choose the right contacts that we want to use, and we have to choose the parameters. So one of the studies that I did with Benny, that was our first time to do DBS in Israel. That was a multi-centered European study that started, I think, in 2011. And we recruited 9 patients for these patients. We didn't want to make a sham or controlled study because we knew that it will be very difficult to take the most resistant depression patients and ask them to get the implantation and then wait for 6 or 12 months until they will get the stimulation. So we decided to make a crossover study comparing 2 different frequencies of stimulation. So we used high frequency and low frequency stimulation. And as you can see, most of the patients here in green got some kind of a benefit, like a little bit more than 20% reduction of their depression score. But most interestingly, you see this group of patients. These are the patients that got low frequency stimulation and then high frequency stimulation. And these are the patients that actually did best. You see here a patient that had high frequency and then low frequency stimulation, they did a little bit worse. So we know that low frequency stimulation that we are thinking that will not have any benefit for depression did better in the first period of first 6 months, and only at the second part of the study, the high frequency stimulation was better than the low frequency stimulation. Does it make sense? Not really. Did we explain it beautifully in the discussion? Yes. But this is the notion that when we get into a new area of the brain, we don't actually know how to stimulate it. For example, the high frequency stimulation, why do we use 130 hertz? Anyone? because that was the frequency for the ablation many years ago. So they used 130 hertz, so everyone in the DBS field uses 130 hertz. But if I have to try all the frequencies, all the durations, all these parameters, this is of course endless, and I can't do it in my practical use. So we don't know what are the parameters, especially for new targets. And in psychiatry, we have some more challenges. The first is that it takes much more time for response than in Parkinson's. So Dr. Sackeim showed you the beautiful videos that we show, the on, off DBS for Parkinsonian patients. But I cannot show you anything like that, not in depression and not in my OCD patients, because it takes time. It takes time until these plasticity changes occur in the brain and we see the clinical benefit. So if it takes time, of course, that I cannot change the stimulation according to the patient's state. I can ask him, how did he do that in the last 2 weeks? What happened? To evaluate his function, and then to make my own estimation about the changes in the parameters of stimulation. Another thing is that the symptoms are related sometimes to a specific stimulation or situation or location. For example, if you see a depressed patient in the morning or in the evening, his clinical state would be different. So how would I know how to stimulate? Or if I see an OCD patient who now has these obsessions about coming to my clinic, so I'll see a flare of the OCD symptoms. But if my patient has only obsessions about like washing hands, so in my clinic I will not see any symptoms and I will not see any change when I change the parameter of stimulation. So our way to answer these things is to use a closed loop stimulation, where we have to identify the pathological activity and to correlate this activity with behavior and make sure that we are stimulating the right thing. So as I showed you before, we make recordings of, here is the STN, but then we look at the specific frequencies of the activity. And the most interesting thing is this area, which is the motor area of the subthalamic nucleus, where we can see the beta activity. We see oscillation in a specific frequency, which is like, maybe I'll ask you a few questions. Siona, how long have you known Benny?
50 years.
50 years. Amit, how long have you met Benny?
Oh, not 50 years. Yeah, I know him before. No, I'm about 15.
About 15. Okay, so I can ask everyone, so I'll just ask everyone another question. Please tell me if you have met Benny in person before. 1, 2, 3.
Yes.
Okay, so now I got an answer from all the cortex. Okay, it was not individual neurons that answered my question. So I don't have the details of when did you meet Benny for the first time, but I have a notion that most of the people here answered me together, yes. So if I have this oscillation, it actually helps the cortex to communicate with other areas of the brain, like it communicates here with the subthalamic nucleus. So I can get some, the big picture, I can get an answer. I lose some details, but I get a real notion that most of the people here knows Benny, or that something is wrong with my motor systems here. I can look at the spontaneous activity of spikes and local field potentials, and I can also record while I use some motor, emotional, and cognitive tests. So one fundamental question is, what do we record? Okay, if someone now gets into the room, okay, and hears me, okay, so he can know that he hears the subthalamic nucleus. But there is also a lot, this is like some kind of noise that we have in this area. Maybe we can say that actually what you hear is the cortex, Okay, when we record here, you can also say, okay, you put your electrodes, but the subthalamic nucleus is so small and the cortex is so big and makes such a noise in the brain. So what you record is actually not the subthalamic nuclei. So I will not get into detail, just to let you know that we found that if you use bipolar recordings of macroelectrodes, we can ensure that we actually record the activity within the STN and not just recordings from the cortex. Another thing that we had is the Medtronic new pacemaker that can not only pace the brain but also can record for a longer time after the surgery. So now we can get recording inside the OR, and we can also get recordings like weeks and months after the implantation. So the first thing that we wanted was to develop some tests that will enable us to use in psychiatric patients. And the first one was a test to record the emotional state, and we found that we can actually define a specific area in the STN that we can record the emotional reaction, and we can see it only on the non-dominant STN. We now moved into the area of the cognitive abilities, and we show here that in the same area of the STN, there is a difference when we ask the patient to do a simple go, no-go test. There is a difference between the go and the no-go, and that means that we actually can differentiate also the cognitive areas of the STN. And these tests are actually used in the OR to find exactly where is the motor, the cognitive, and the limbic areas of the STN in PD patients. So I think Dr. Sackeim that we actually can do an individualized implantation today. To find a specific pathological activity for psychiatry was another challenge, and this is a work in our first OCD patient that we treated here in Israel. And you can see that in OCD we found a very interesting and specific activity in the cognitive or limbic area of the STN. So we actually found a specific oscillatory activity in the theta range that is specific to OCD. We also showed that this specific activity is correlated with the state of the patients, because we had this opportunity to record during a few months after the implantation. And we showed that the activity at the theta range is correlated with the improvement in the patient state. We also used some specific OCD provocation tests, like during the surgery and after the surgery, to provoke the OCD of these specific patients. And we showed that while provoking OCD symptoms, the theta activity is also changed. Okay, so now we talked about the targets, getting into the target stimulation, and now we have to select the right patients. So of course there's a big debate who should get the DBS therapy. We'll keep it today to the most treatment-resistant patients, but I just want to remind you that an interesting work that was done with Parkinsonian patients showed that with DBS there is a neuroprotective activity. If you take patients with early Parkinson's disease and compare patients that got DBS to patients that got the best medical therapy, after 2 years, you'll see that the patients with the DBS, even when you turn off the DBS for 2 weeks, are doing better than those patients that got only medication. So we now treat only the most treatment-resistant patients, but maybe in the future, because of the protective activity of DBS, we will have to consider treating patients early in the course of the disease. It's very hard to study DBS in depression, and you all know the negative studies. I think that most of the studies in the DBS graph that you showed are actually ethical questions about DBS, or why did we get all these negative studies for DBS? So that was the biggest depression study for DBS that showed that there was no different between the active DBS and placebo or actually control group. These are patients that got implanted but didn't turn on the DBS device. So we know that there is a huge effect of a placebo for surgery, and we know today that it takes time to find the right parameters for stimulation, and then until the patients get better. So if we look at the OCD studies, they did a different thing. They implanted all the patients, and then after a few months they turned off the stimulation, and you see that the OCD symptoms return. And maybe this is a better design, and if we would done this for depression, we would maybe get some different results. This is another on-off DBS study for OCD. So if we look at the clinical outcomes for depression, they are not so good. Today we don't have a real clinical evidence that it actually works. Maybe the target was not perfect, maybe the design of the study was not good, but if you look at the outcomes for OCD, this looks like really good. If you take the most treatment-resistant OCD patients, there is a reduction of about 45% in the Wild score and 60% of responders. So if we think of the future ahead of us in the DBS field, we have to look for new targets, and now we are smarter. We know where to look, what would be the best target for DBS, how do we get into the specific location using imaging and what we call functional electrophysiology, how we set up the stimulation with closed loop I hope in the near future. The patients, we look forward to start with some new indication like negative symptoms for schizophrenia. And I know that during my stay at Boston, there were no treatments here, but now I'm back and we'll start again treating those most severe depressed and OCD patients. And of course, how to plan the studies that would fit not the pharmacological studies or paradigm that we know, like phase 1, phase 2, sham control. We have to be more creative and think of how do we plan studies in psychiatry, in surgery, in psychiatry. So these are my colleagues now, my friends at Harvard, Dr. Reese Cosgrove from neurosurgery, David Silverswag from psychiatry, and Emily Stern from neuroradiology, and my friend that you know most of them, my DBS group in Israel. And I'm looking forward to come back home and continue our work together.
Maybe one or two quick questions.
Well, thank you very much. It's been extremely interesting. One question is I've always been curious to see whether one possible guideline to find out this parameter that you said are very important can be just the EEG recording of the frequencies in specific area, maybe with high density EEG for these particular patients. And we have data in my lab showing that there are some kind of particular variation in EEG frequencies for different type of disorders, right? So maybe just a naive or stupid question, but I don't know whether you have ever tried.
So the question was why do I have to use the recordings from the DBS electrodes and not just the EEG electrodes? So the truth is that we are looking for ways to use the EEG recording for guidance of the DBS and for stimulation. So I have now two sets of data of the most detailed EEG scans and my recordings from only 4 patients with Parkinson's, and I can tell you that recordings from the electrodes deep inside the brain is much more accurate. We have now algorithms using machine learning techniques to define the specific changes that we see in Parkinsonian and in OCD patients that we had here. We also had the EEG part, which is interesting, but I think that once we have electrodes in the area that we want to stimulate, the data is much more interesting and promising for these kind of closed loop paradigms. Yeah.
two comments. One, I think you're absolutely right that the duration of the observation is critical in these patient populations. LivaNova, which is a company that now produces the vagus nerve stimulator, is starting a 400 patient study in the United States where their sham, where people are not turned on, is 15 months because it takes a year before you see clinical response in depression with VNS. And people like Mayberg think that they actually got much better results later in time. That we don't, it's absolutely true that you don't see it immediately when you turn it on. So we may, and there are all sorts of ethical issues about how can you keep somebody in sham for that long a period of time. So that's one issue. The other issue, which isn't discussed a lot in the DBS depression literature, is the Mayberg target and Lozano's target, hopefully they thought was the anterior cingulate. The anterior cingulate is a huge gray matter body, and the DBS signal does not broadcast very well in dense gray matter. And so they went below the anterior cingulate actually and were stimulating in the white matter, hoping that they would modulate the anterior cingulate by stimulating in white matter. We don't have any map of the white matter. We don't know where in the white matter you can go to impact on the anterior cingulate. So in many ways it was very blinded work, trying to impact on one target by going somewhere else.
So that's the main idea, to use a more focal area of the brain. We hope that we'll have better answers for depression also in the near future.
Thank you very much, Renana.